And this is Miguel. I'm here with Michael.
Oh, great. That's wonderful. Thanks for joining us, Miguel.
You're welcome. Just let me know when we're ready to start.
Yeah, I think, as I was saying, I think we're just going to give it up until, maybe 3:03 for people to kind of get on the call, and then we'll go ahead and get started.
Okay.
So, but I'll go ahead and give you the green light.
Hi, Carla. This is Patty. I just wanted to say hi.
Oh, hi, Patty. Thanks for being on the call.
Yes. And sorry I missed last week's call. I couldn't make it.
Oh, yeah, no problem. We did record it in case you're curious at any point to listen back to it. So just let me know if you need that link.
I will. Thank you.
Yeah.
Hi, Carla. This is Dan Gallagher from Sandax.
Hi, Dan. Thanks for joining in today.
Thank you for hosting.
Hi, Carla. It's Trav.
Hi, Carla. It's Belinda from Long Beach.
Oh, great. Thank you for joining us.
Hey, it's Amy in Orange County.
Hi, Amy. Thanks for being on the call.
Of course.
Who else just joined us?
Hi, it's Stefan.
Oh, great. Good to have you on the call, Stefan. Okay, I think since we've reached our 3:03 witching hour, I'll turn it over to Michael, who is one of our Healthy Transportation Team co-chairs, Michael Ozier, from Riverside Health, and he can introduce our call today.
Excellent. Thank you for putting this together, Carla, for introducing our Urban Footprint Health module. We have two speakers today. Joe DeStefano will do a very, very brief recap of what he presented 10 days ago. And then we have the honor of having Dr. Larry Frank from University of British Columbia. Joe leads the regional and large-scale master planning team at Calthorpe Associates in Berkeley. We won't hold that against him, being a Northern California guy myself. And Joe leads the deployment and development of the rapid fire and urban footprint modeling platforms, which is why we have him here today. And then followed by that, the most of today's meeting will be from Dr. Larry Frank. Born and raised in Rochester, New York, of course, he's the president of Urban Design for Health and a professor, the Bombardier Professor at University of British Columbia, focusing on transportation. Since most of you did not hear Dr. Frank last time because he didn't speak, he focuses on travel behavior, land use, public health. He has two major books, The Health and Community Design and Urban Sprawl and Public Health. And many of us have used that book, and Dr. Dick Jackson was a co-author of that book. Dr. Frank has over 100 published articles and been cited thousands of times, and if you hear anything about public health, transportation, and built environment, and Dr. Frank isn't cited, then you've read the wrong journal. Anyway, Dr. Frank will be presenting the health module part of Urban Footprint. And Joe, this is just a brief recap. You have 5 minutes, and then we're going to cut you off so we can hear Larry. Joe, you're on.
Great, thanks so much. I'll try to take less than 5 minutes, and I'm born and bred in Southern California. So that gives me like points with this group. LA, city of LA.
All right. Good now.
Yeah, there you go. I defected, but I still love it. In any case, yeah. So just really briefly, for those of you who were not on the call last week, we, in the context within which the sort of public health advancement is occurring, is the urban footprint model, and that is a sort of a land use and scenario development and analytical tool/ecosystem that was developed in response to the state of California. What we've been doing regional planning for a long time, but ultimately a few years ago, the state of California basically asked this sort of big question related to AB 32 and then subsequently SB 375, which is what role does land use play in not just carbon emissions, which was the regulatory window, but what role does land use play in sort of meeting the whole myriad array of California's challenges related to water, energy, pollution, physical impacts, household costs, a whole series of other components, and of course not the least being public health as it relates to respiratory, autopad collisions, and also active transport related disease incidence and costs, which is what we'll focus on today, or what Larry will focus on. So what we ended up building two novel models. We basically broke down most of the proprietary systems that were in existence based on the sheer data size and the analytical needs of the exercise. And long story short is we've created, using UrbanFootprint, which is a web-based open source geospatial model, which I showed last time, and which I think that was recorded, and I'd be happy to review things with people subsequently. We created a set of proof of concept scenarios which represented sort of a business as usual and sort of range of futures, but ranging from business as usual to something that was like a stitching together of all the sustainable community strategies and regional transportation plans in the state of California, asking the question, what role does land use play? What if we continue to grow as we have been versus what if we grow in more compact forms, what around transit, active transport investments, and things like that? And then express the impacts related to that whole range of indicators I talked about, so energy and water and emissions and public health, et cetera. We delivered that model, if you will, sort of a code and capability to the state of California in 2012. We worked with funding from the High Speed Rail Authority and also from the Strategic Growth Council, part of their competitive model improvement bids, grants rather. And we have subsequently, over the past 12 to 18 months, been working with three of the major MPOs in California: Sacramento Council of Government, SANDAG, and now SCAG, to deploy and develop the model for their use. And so building out a very significant software undertaking in which we've been building out a web framework so that folks within those agencies and then ultimately within cities across the state of California, NGOs, et cetera, will be able to access the sort of capability of this tool set to be able to inform better general plans, climate action plans, regional sustainable community strategies. SCAG will be utilizing it in this upcoming or in this current round. SACOG is currently utilizing it in its production of its SCS alternatives. And then we worked last summer and fall with SANDAG to produce a first round of alternatives and model them using the UrbanFootprint system. So the first version of the public health module, if you will, was developed with Larry. And mostly by Larry's team, and integrated into UrbanFootprint's sort of uniquely detailed depiction of the land use environment on the ground. And then we're now working with support from the Strategic Growth Council, California Endowment, SCAG, and SACOG, among others, to advance that and customize it for the California condition, which Larry will talk much more about. So with that, I'll stop. I can answer any questions if we want to do that, or we can just move right on.
Joe will hold on, and I want to give you credit exactly 5 minutes to the second.
Excellent.
Perfect. Next up, and the focus of today's discussion is Larry Frank. And before we move on, understand that these modules that we're talking about do best by comparing existing condition, business as usual versus some change you make, and I think that's an important piece to talk about. Now, Dr. Frank, you're on, and you have 35 minutes.
Okay, thank you, Michael. So, Carla, is my screen visible to everyone?
Not yet. I'm going to do that right now.
Okay,
and thanks everyone for the great presentations and introductions. It was really helpful and great context setting. Does anyone have any follow-up questions to any of the topics that Joe mentioned before we move on? All right, hearing none, I think we'll turn it over to Dr. Frank. Thank you for joining us.
Thank you very much, Carla, and thank you, Tracy and Michael with PHI for inviting me to present, and to Joe for an excellent context. And so this project is, I think Joe provided a good background. So with that, I'm going to talk about the integrating health into scenario planning tools, in particular UrbanFootprint. and it's really all about creating an evidence-based approach to health impact assessment, which by and large has been more qualitative to date, and that's the goal, is to make best use of existing data and tools and technology to make this possible. So this conceptual model shows a panel. I guess one question I do have for you, Carla, is if I use my cursor, can people see the cursor?
We sure can, Larry.
Thank you. Thanks a lot. Okay, so on the left, basically, this panel, land use transportation, is really about built environment, and there's two pathways to get from the built environment over to healthcare utilization and healthcare costs, and it's through behavior and then through exposure. And so this is sort of a grand vision, if you will, and a lot of the research that's been done over the last 10 to 15 years have been these arrows that link up the built environment panel with what might be a stronger set of causal evidence in the middle along this behavioral pathway: energy balance, affecting body weight and chronic disease, or really activity patterns having a direct effect on chronic disease as well, so both direct and indirect. And then that carries over to healthcare utilization and costs, where we now have, and others are starting to have more research. We're actually trying to connect up the fiscal impacts, which will be very dramatic and very important, and that's more of a direct connection. We'll talk about that in a moment. And then the exposure pathway, air pollution and noise, very important, have an effect on cardiovascular function, not just respiratory. I have respiratory here within this pathway, but cardiovascular would be kind of affected both through behavior and exposure, and that's why urban footprint in the future will have air pollution exposure relationships within it. The first phase that we're developing now does not. So as you know, scenario planning and an overview, Joe did a fantastic job, I'm sure, on this. Basically a method for analyzing and comparing the impacts across alternatives. Typical impacts included financial, transportation, and housing, affordability, and other things. Could be groundwater recharge and ecological factors. More recently, we've been adding health. This is our 5th project doing this. Results are to inform decision-making about the effects of these infrastructure investments we're making on health outcomes and others as well. So integrating health, there's really a growing body of evidence that built environment influences travel, physical activity, and health. And the evidence, as many of you know, has been associative, cross-sectional data. But there actually, in California, recently was a really good study released by Marlon Bornet in LA, Los Angeles, and I'm sure many people on the call probably know of it, where he did a pre-post analysis of the physical activity impacts of the light rail extension and found expected relationships positive and significant, measured objectively, which we like. And I think he also looked at greenhouse gas emissions. So health-related outcomes and costs need to be considered within transportation decisions. Everybody would probably agree with that. The question is how best to do that. And integrating health metrics into scenario planning results in a quantitative HIA tool. I think the perspective is that you're making really good use of investments already made in data and in technology and infrastructure around information to do this. The proposed approach makes the best use of those existing sources. This approach I'm about to share with you has been reviewed really carefully and approved through a multi-stakeholder interdisciplinary peer review panel as part of the Urban Footprint Project, now funded by the Strategic Growth Council and through the Regional Resource Legacies Fund. So it's been, and also was pointed out to me yesterday, is that the same approach that we're presenting today had to be approved. It's the same approach we developed and applied in San Diego earlier, had to be approved by the state IRB board for access to the data, and it went through that process, which is quite rigorous, a number of years ago, and then again recently for us to access the data. I'm actually trying to, oh, there it is, okay. So, so a little bit of history. Our firm, Urban Design for Health, have done this before. We started back in the late 90s, actually, with the Smart Track project, using a tool called Index, which is a predecessor to Urban Footprint. And we used their Livable Communities initiative in Atlanta as a test case where people had developed their own vision of how they wanted their community to grow and documented the health and physical activity and air quality, mostly air quality benefits of the vision that people had for their own community. Then came a project called iPlaces. Well, using iPlaces 3 as a platform, King County added a health module, and we worked with Sacramento Council of Governments using their tool, which was iPlaces. I don't know if it's still really being used. I think Urban Footprint has basically superseded iPlaces in many ways. It has some similar characteristics, but it's better in almost every way as a next generation. And then, of course, Urban Footprint, we added a health module to what Joe mentioned, round 1, which was Vision California, what we called it. I don't know if it's still called that. And then finally, we had 2 different projects using CommunityViz, which is a software platform that Sandag had used, and that's why we used it for San Diego. At the same time, we did a whole other separate project using CommunityViz in Toronto, and then applied the results across Canada to a place in British Columbia. So in Atlanta, this tool, Index, is developed by Criterion planners, but basically we looked at vehicle miles traveled, we looked at transit use and vehicle emissions, and assessed changes resulting from proposed. So in Atlanta, these 3 communities, West End, Marietta, and Perimeter Center, all went through major planning processes to account for how they were going to grow. And we tested their growth alternative. And I think Michael pointed out that's comparing current condition to some future aspiration. So that was interesting, and it was used to and successfully supported ongoing funding for these Livable Centers initiative, which has amounted to date to several hundred, probably close to $1 billion of infrastructure investment in existing centers. It's a real philosophical shift. And this data was really helpful for people in those communities to see how investing in their existing communities rather than growing more outward was helpful. In King County and Seattle, our project was to focus on programming this next generation. And I guess Joe made it really, I'm sure made it really clear that Urban Footprint has a lot of horsepower in it because it can draw energy or, well, computing power off the internet. And that and iPlaces here was really an advancement that came out of SACOG, which was the first scenario tool to do that. So we used the SACOG tool, and we developed a model that predict health outcomes. We looked at a body mass index. We looked at physical activity measured objectively, vehicle emissions. And so we had a lot of different outcomes. You can see them here. And we also did greenhouse gas emissions, and that was published in the Journal of American Planning Association paper called Many Pathways from Land Use to Health was the research that went into that model. It was pretty interesting. It was the first model to really bridge energy, environment, and health. So now Vision California, round 1, the pilot, and just quickly doing these and then getting into what we're doing now, but this is how we got to what we're doing now, and I think it gives you sort of the generation. I don't know if you've seen a map like this, but this is a predicted variation in moderate and vigorous physical activity. The tool was Urban Footprint, and we applied it statewide. But this time, last time, we created statistical models, and then we programmed them into the software like we will now. But we had to use data from other places. But we looked at physical activity and obesity, and then we predicted obesity-related health conditions and cost. Another group worked on the respiratory side, and we helped with vehicle and pedestrian collisions as well. And Joe mentioned that. This is the data we used. We used data from Seattle, from King County, and from Atlanta. So as you can see, but we had a really pretty good sample size of objectively measured physical activity data and time spent in cars from Atlanta. So just a real quick background on those tools. This is the predicted surface blown up for San Diego that came from Urban Footprint round 1 that from a face validity perspective makes good sense to us. We can understand why the areas that are darker blue, where we predict more physical activity, would have the increased levels of objectively measured physical activity based on the urban characteristics of those areas being more supportive. Now, what happened after that, this is just kind of the predecessor of Urban Footprint Round 2, or the statewide tool, was the Sandag Healthy Works project that I think most people are quite familiar with. So here we use community viz, and health models were developed from the integration of built environment data with local health and behavior data. We had a lot of help from people in San Diego at the County Health and Human Services, really pulling together a lot of data layers with us. We used the California Health Interview Survey, and the reason I want to talk about this is really we learned how to use your CHIS, Health Interview Survey data, and the California Health Interview Survey data. If I use the acronym CHIS, that's what I'm referring to. And then the Household Travel Survey. So it's analogous to the approach being done statewide, but it was done in a bit of the microcosm, not really, but a microcosm, but just the geography of San Diego to learn how to do this. It worked quite well. Users conduct scenario planning using detailed transportation. Basically, we used the detailed data that was available in San Diego, and we forecasted health impacts, including physical activity, obesity, and some chronic disease. Same methodology and data now approved for the new statewide urban footprint tool was used. But more detailed built environment data was available in San Diego that informs us how to use that data when we can get sidewalk data and park data and food environment data statewide. That tool also included safety and air quality outcomes, so it's really a good pilot for us to learn from. Here's Utilitarian Walkability that's part of the Sandag's Healthy Communities Atlas that many of you are familiar with. I think Stefan's on the phone. He led that project and developing that atlas with us. And multiple components that go into the Walkability Index. So that was the first large study to spatially match prevalence of health outcome data. So this is a big issue, is it's a jump forward to use a health interview survey in this way. And we know it and recognize that. We were able to get address information, and that's the key, and build detailed urban form predictors of 18,000 participants from San Diego in the survey, and it just leveraged a whole lot of NIH funding that Jim Salas and my colleagues had on built environment in San Diego. So it was a great kind of a really effectively $5 million worth of data being accessed for basically a fraction of the price. And then we learned a lot linking walkability, regional accessibility, a lot of transportation people on the phone, so I don't need to probably define that, but it's travel time, how quickly you can get to places across different modes of travel. And we looked at type 2 diabetes, cardiovascular disease, respiratory, obesity, and other ailments to see where we would find significant relationships or not. And the results are forthcoming. And so summary, what we've learned is relationships between health and built environment is generally consistent with expectations. Urban form or built environment relationships differ, however, by age group. And that's a big issue for us that we're addressing in this new project. And I'll get to that in a minute. Parks and sidewalks are important in predicting a number of health outcomes, as we had suspected. Connections between increased walkability and higher pedestrian and bicycle collision rates was important, and actually kind of an area where more exploration and research is needed. Very significant negative impacts of living near major roads with high traffic volumes, especially in youth and teens. We're seeing across a number of health outcomes. So just real quick, many of you are familiar with, of course, Interstate 5 goes all the way through California down near the Mexican border. This outline here that I'm showing is a study area where the results were applied. It's called Palomar Gateway. And the base case, and what I want to point out is here the total population of growth is going to go about 3,000 more people are going to move into this area. They're projecting through this is their OCP, this is their comprehensive plan, and this is what they call for about 3,000 more people moving into this area. Many significant changes to the study area, but in the interest of time, I'm just going to show you what we learned through our model and the most significant changes are in the darker green. Lots of walking for transportation, about a 10% increase, which we think is reasonable. I'm sorry, from the base case, it's a 67% increase from 6.1 to 10.24 minutes. people do know, and I think most on the phone would be aware, that this is an underreported sample of active transportation from travel diary data, but the proportional change we think would be probably consistent. So it's just projecting upwards based on that baseline data. And then we see significant outcomes in minutes, daily minutes in a car, a significant reduction of about 8%, but interesting results overall. And I guess the diabetes one was one that, so we see about a type 2 diabetes, a 7.8, the number is about a 9.62% reduction, 10% reduction. And that number, if you were to kind of conceptualize that within the context of 3,000 people, could result in a significant reduction in numbers of diabetes onset or other outcomes. So we have interesting results. High blood pressure went down by 15%. None of these are earth-shatteringly huge numbers, but that actually makes us more confident in the results because they seem fairly reasonable. Just mentioning that we did a similar project in Toronto. That work has been widely released now in Canada and is starting to get fairly well promoted. And I'm just going to skip that in the interest of time, but let me just go back and say just one thing about it is that in that project we incorporated greenhouse gas emissions directly into the module. So what you've seen are some studies where we bring other travel-related health impacts, such as air pollution, into the tool directly, or greenhouse gas emissions, which is not directly health but environment. So there's a lot of flexibility with scenario planning tools to bring in other outcomes. And of course, what's so good about it is a decision maker can look simultaneously at a bunch of different factors when making a decision about how a place should grow. So now into the modeling approaches. There are two different really distinct ways that we go about this. One is, and this is a bit of a technical discussion, but it's important, I think, to know. And this is what a lot of the debate is within our advisory committee that Elizabeth's a part of and Michael's aware of on our new project, and Joe's, of course, an intimate part of, is so we can do a direct approach, which is where you apply, basically apply to all, so this was how Healthy Works did it, was basically we use data from a single data set to estimate built environment and health relationships. So on the same people, we know where they live, we probably know something about their physical activity patterns, their diet, their behavior, their exposures to different kinds of bad things or good things in the environment, helpful or health inhibiting, and then we have their health outcomes, all in that same data set, all locked together. That's what we call direct. So the strength of that approach is it uses local data, and results are generalizable to the local area because those are the same study participants are in the same region that you're actually generalizing the results to, as long as it's representative or weighted to be so, which we, of course, made sure of. Linkages between the built environment and health are then derived from the same data sources and represents known relationships within the region of application. It's very important. The weaknesses is we may not have all the data there that we need. It may not be possible to form all desired linkages within a single data set. Local data may not be available or suffer from limitations, such as being cross-sectional, which is the case, scale, self-reported as opposed to objectively measured physical activity. So you can do this. Alternatively, is you can borrow data from other places. So that's what we did in round one of Urban Footprint. We borrowed data from Seattle and Atlanta. We applied it to Vision California through the chronic disease models. We pivoted off of obesity or physical activity. Both can be done. As many of you know, ITHM is another tool. It pivots off of physical activity. It generalizes from data collected elsewhere. So these are some of the things that we discussed. Typically combines local data with external evidence, so published findings to estimate built environment and health associations. Strength, published evidence from around the world can be stronger. You're pulling on more data points and can have some composite evidence, and that can be sometimes provided by a local data source. However, the downstream results are restricted to only one pathway with no direct effects. So once you pivot off of a given factor, you're kind of stuck with whatever the published literature says about that particular factor, data from other places are often unique and not generalizable. That's a really big issue, and that's one that we're learning a lot about now, and know that that's a primary reason for us to want to make the best use of the data that happen to exist in California, which is the health interview surveys, a really wonderful data set, and we feel if it weren't the case, it didn't exist, then of course this would not be our approach. But the public may not also have as much confidence in results. So, for example, we're not, in California, like people from the UK and elsewhere in Europe or wherever other studies are done on how we travel and get around, and the exposure to transportation options are completely unique. So, when the public kind of asks, where's the data come from that this tool is being used, it's going to be great to be able to tell them it's from here. It's from our own data of you. It's our population, and it's our own monitoring system that we use to measure prevalence of disease within our own community or communities. So the direct approach is what we've proposed in the first project in San Diego, now in Urban Footprint, and the reason is, as I mentioned, the strengths are what they are, and I'll get into that in a moment. We're not the first to do it. This is a list of several studies that have been published in the literature, very well-received science around direct connections between neighborhood characteristics and hypertension. Lots of studies, built environment and changes in blood pressure in middle-aged older adults. There's a lot of people that have made this direct connection through their research, and there's a lot more, so it's not unique and new. So moving forward, the Urban Footprint Public Health module builds off the growing body of evidence that built environment influences travel, as I mentioned earlier. Health-related outcomes and costs need to be considered. So repeating a slide from before intentionally, just to get back to the point here, is integrating health metrics into a scenario planning software tool and then creating health impact assessment tools. So Urban Footprint's public health module makes use of the local data and these new methods, and recommended methodology is largely based on the Sandag Healthy Works project. Modeling emphasis is based on behaviors and outcomes related to physical activity, however, and will be expanded soon to include air quality and other safety outcomes that I know are of concern to you. The project team members are here in terms of the advisory committee that oversees the health work itself. In addition to the organizations on the left that you can see, the technical advisory committee includes folks from UC Berkeley, from the Safe Transportation and Research Education Center, Center for Disease. We have members from the Center for Disease Control, some consultants as well, RSG, Resource Systems Group, UCLA, LA Department of Health, RAND Corporation, and others. So I'm going to stop and ask if I'm audible and still being heard, because I have once done this and actually found out towards the end I wasn't.
You're being heard just fine.
Okay, cool. Thank you. So I'm not going to go into all these little details on the right here, but I want you to look at the pyramid on the left. So when we build a tool, a software tool like this, the first thing we need to do is assemble all the data, create all the measures, and with San Diego, with the Sandag project, we produced an atlas at that point along the way because we needed to get all the data anyways, but we were on our way to building a tool. And then we do multivariate analysis where we look at multiple factors. This is where the modeling is done, where we relate different phenomenon of built environment and health outcomes. We then take that information where we extract the relationships or the coefficients, sometimes called elasticities, slightly different, but for this discussion it kind of gets the idea across, is how much of a change in Y or change in an outcome do you expect for a change in a given built environment feature? And we do that and then do sensitivity testing on these relationships. So that's where we start to build the results into the software tool, and then we apply it. So this is the conceptual framework, and a lot of our debates have been over these relationships. Is that on the left, of course, we have who we are. Our sociodemographic and covariates. So there's demographic and other socioeconomic factors are covariates. And then the built environment characteristics are independent phenomena, but of course related. And those factors then affect physical activity, they affect body weight, and health outcomes. So the questions are how we structure the analysis to account for direct, that would be this line, from who we are, or built environment features, or indirect. Do we model, for example, obesity or physical activity as mediators between built environment features and health outcomes? So I hope that makes some sense, but that's what's known as structural equation modeling, and that's a big point of discussion for us on our working group, is to figure out what's the best way to replicate the real world in our model. So Joe, I bet, covered this fantastic, very well in his talk, but data is available for 30 counties across 5 regions. This is a big advancement for us because having a diversity of built environment characteristics, people located in lots of different places, is very, very important. So you have the 5 regions, as you're aware, and then this is all California-specific data, which we think is great. Data sources provide all the information that we really need. It's weak in some areas, and definitely this project and others give rise to informing how data collection protocols may be adjusted in the future. Some things without much cost could make the data a lot better for this, and other things will cost more. So as you know, urban footprint built environment data, I bet that was presented last week very well. The California Health Interview Surveys are our health outcome data set, and we also are using the California Household Transportation Survey, also just completed. So I made that point a lot. The first one, the CHIS this is the health and transportation data, have large sample sizes. Big issue for us is the multi-region data provide high variation in built environment and behavioral characteristics. Models will be uniquely fit for a range of age and income groups. So this is a big point, is that in all the research that we've done, and I've seen from others, is that our relationship with our environment varies considerably based on our age, income, and other demographic factors, but often we don't have enough data to just isolate people into their unique demographic cohorts. This time we do. And in fact, we also have the ability to look at how they might vary across a wide urban terrain, from the most walkable parts of San Francisco to the least walkable suburbs of any given region. So it's an excellent use and leveraging of existing data and public investment that you've already made. So on the CHIS data, what we're proposing to do, it's the largest regularly conducted health survey in the United States. Every other year it was conducted between 2001 and 2009. As of 2011, it's now conducted slightly different way. They're collecting the data now. It's done continuously over 2-year periods. Each survey includes between 40 to 50,000 participants, households, and 3 unique survey instruments. There's an adult survey, teens, and then children. Participants' home locations are geocoded. Data, it's not typically analyzed at the address level for confidentiality reasons. Individual health-related behaviors, health outcomes, and relevant covariates are captured. It's all done by phone in all 58 counties of California. And it's
Larry, this is Michael. You have like 5 or 6 more minutes, so do you want to make sure you cover what you need to cover, because we have other things we have to cover as part of this.
You bet. Thank you, Michael. Okay, so basically, this is the transportation survey. It's 42,000 people. I don't have time to talk about it in great detail. It has a GPS subcomponent, which is important. That's objective travel data, and we're trying to make use of that. A big theme in our discussions has been over validation of results, and that's a good data set to validate the travel data, which is self-reported. The built environment measures that we will be using are familiar to most of you. Density, retail FAR, which is the ratio of floor space of retail to land area. I can talk about that in a moment for the non-urban planners. Most planners know that one. Land use mix, and then we are looking at park space, connectivity, intersection density, and we're investigating we really need regional accessibility, which is a travel time metric to know the effect of regional location, transit level of service, street network density. Anyways, we're looking at distance to nearest establishments. Non-motorized infrastructure will not likely be available for the first study. Anyways, we're getting into discussions around the spatial method to buffer around the participants. Urban Footprint gives us these really nice grid cells, and we have to decide if we do a network or a crowfly type of a buffer. We've made a decision. I probably won't go into the details about that, but grid cells are 5.5 acres data, and that's the Urban Footprint grid. And Joe, did you go into the details about the grid at all?
No, I didn't. I stayed pretty high level.
Okay. So anyways, there's a lot of details around the data. Variables were calculated for every survey participant home. So we're matching up the data sets that I mentioned, landing them on this grid, getting the measures, and then doing the modeling work. And lots of information about that to discuss in a subsequent call. But these are the demographic characteristics that we're looking at that will be derived from the CHIS and travel survey. CHTS is the travel survey building, and then also from the census and other data sets, age, gender, ethnicity, educational attainment, employment, ownership of home, income, household size, and vehicle availability. I think I'm going to skip this in the interest of time. I think this is, but basically to note that we'll be modeling both direct and mediated pathways. So here's the built environment, physical activity, obesity, health links, all in the same data set, integrated. Built environment come from the Urban Footprint grid, and so forth. So, and then with the California Household Travel Survey, we'll be looking at built environment links with physical activity, and also not shown here, but time spent in cars, which is a really important sedentary time factor. Fairly technical issue that I won't go into today, but I wanted to bring up and mention is over model fitting and variable selection. We haven't had one conversation without this being a major topic over the appropriateness based on different cultures, whether they be in public health or in urban planning, about how you go about selecting variables, putting them in a model, keeping them or rejecting them. We're using a variety of statistical methods we're quite familiar with and testing new ones all the time. So if you have any questions, that can come up in the Q&A part. And then I think I'll just move on. Expected outcomes from the project is a health impact assessment models that will be integrated into the Urban Footprint software. Urban Footprint will provide metrics for predicted daily minutes of physical activity, prevalence of overweight and obesity, and then prevalence of related health outcomes, probably high blood pressure, cardiovascular disease, and type 2 diabetes, and it will be probably limited to that. Models are to be used for long-range transportation planning, regional planning, local planning, etc. And towards conclusion, the piece coming up that we're now got that we've received funding for, which is exciting nationally, is around the fiscal impacts of the built environment. So that's the next piece to come. And many of you may know the hidden health cost of transportation, where it came out about 3 or 4 years ago from APA, American Public Health Association, that we wrote for them is a place to think about it. So in summary, where we build and what we build in terms of infrastructure, we know has a relationship to what a developer will choose to build and where to build it and how to build it, and where we will choose to live. And we think that affects our behavior, our health, and how much healthcare costs and how healthy we are. So I thank you and look forward to questions and discussion.
Thank you, Larry. That was fabulous, and you made your time exactly. Now we have Dr. Baca is going to take the last 5 minutes, so we have approximately 10 minutes for some questions. My question, if I may start, since I'm that prerogative, if the Larry, if the CHIS data really isn't, I thought it wasn't valid at smaller than like a region approach within a county or a county approach. So how can you do those grids with CHIS data?
Because you're applying it cross-sectionally. You're not using just that one person in that one grid cell. You're actually integrating. You're loading them up with similar people in similar conditions till you hit a statistically significant sample size. And that's the way the data is generalized than cross-sectionally. We're not speaking about how if it's only the Smiths that live within let's say a given area, and they're in the survey, and we're not going to make the model isn't just based on the Smiths. It's based on everybody like the Smiths of similar income, household characteristics, in similar urban form conditions. The way the statistics work is that you power up based on like conditions.
Okay, no, that's good. I didn't understand that before.
It's a hard question, but yeah, that's the way the way it works, and that's how insurance companies are using, thinly sampled data. Travel surveys are all based on thinly sampled data. No one has the resources to sample statistically significant at the local area. We just, it's very rare. It's just when you're doing like a study of a neighborhood, you may get a grant to get 50 or 100 or 200 people in a spot.
I don't want to hog this. Do other people have questions about the methodology or how this can be used on the health modules?
Hi, this is Rai. Can you hear me?
Yes.
I guess my question was the timeline for monetizing the benefits or the cost, I guess.
Okay, so that's a separate NIH grant, and it's not even that one is we've got two of them actually. One is NIH and one's from another funder. That's not funded through Urban Footprint or even part of Urban Footprint yet, but we have made some attempts to get funding to do that, and we will again. And we have a proposal written, and so hopefully that could happen within the next. I mean, that's a real high priority. I would hope within the next half year that funding is in place to do the analysis to attach fiscal impacts. Now, that said, it is possible to apply known relationships between variations in health outcomes that are tied to built environment features from, like we could pivot into, so to speak, indirectly into health outcomes based on published evidence around how much does a case of diabetes cost, or you'd have to come up with a kind of a calculator spreadsheet tool to do that, and that's probably very reasonable and pretty inexpensive, but it's not going to be as good as if it gets measured directly.
Thank you.
Yeah, good question. Other questions?
My question more is regarding that we could compare the two scenarios, and you can actually theoretically say the rates of diabetes between the two models. You could actually theoretically predict that, Larry?
Yeah, you can take two different built environments and then show what the relationships would be based on activity patterns, or basically the direct relationship between the design of the places and what the health characteristics are in those locations. And in the CHIS data, there's a measure that tells us how long people have lived there. So that comes with the assumption that the relationship that you see between a health outcome, a morbidity, and a place is a function of the variation in behaviors that you would think happen in those locations. And there's good reason to believe that would be the case, and that's what we try to model in our work. So yes, and it would be the relative effect. So you saw in Palomar Gateway there was about a 10% reduction in the likelihood of diabetes, a modest outcome for a fairly significant change in built environment, but 300 cases of diabetes might save you a lot of money.
Especially if you did it across a whole region or Southern California.
Could be huge. Yeah, I think the indication is that the built environment's effect is probably modest, but when washed across the population, could be extremely important fiscally and obviously for quality of life.
Larry, this is Tracy. Can you hear me?
Yes.
Okay. I have a question. If I am recalling correctly, I think last week Joe did also show that Urban Footprint is collecting something around air quality and also safety collisions. And you had kind of mentioned at the beginning of this one that was something you were looking at doing in the future. And I'm wondering, what is the capacity within the tool right now to look at that, and what are the plans for incorporating that?
So thank you, Tracy. So the capacities, I mean, the tool is perfectly capable of being able to integrate. We can integrate these results into the tool. There's nothing limiting us other than we have to collect. We need data that allows us to link air pollution exposure directly with the places people live, and and then map, like we did in Healthy Works, we did that. But we need a really good air pollution exposure surface, and not just for particulates, but for ozone as well, which is obviously a completely different phenomenon. But I believe and have seen that data does exist. So it's a question of bringing in the independent surface, the predicting the air pollution exposure surface, and then modeling the relationship between the exposure to air pollution and people's reported health characteristics through the CHIS data. And that's important because we might make an assumption that a physical activity benefit is gaining a cardiovascular, okay, more walkable, you're therefore going to be more active and your cardiovascular risk should go down. But for seniors living near busy streets, that may not be, we may not observe that. So we might have error in our data or not see a significant relationship that might exist but is being attenuated or actually nullified by a countervailing force.
And the same thing on collision data?
Yeah, that's the Switters data, and we've used it before. California has excellent data, I think, on both of these. I know on the crash risk data. So that can be incorporated in as well.
You would expect an increase in pedestrian injuries on more walkable areas.
We saw it in the if living near a busy street for the teens was like very bad in many ways, including asthma. So asthma is pretty well documented in the CHIS data and other respiratory ailments for youth, and heart condition and cardiovascular function in seniors, but also probably asthma too. You guys know more about that than me, but it's definitely important that those phenomena be captured. And interestingly, we can talk more about it, but we noticed there were other relationships that we found living near a busy street that we thought would have been absorbed by income, that were curious to us, and it just might be that the income measure in the census data doesn't really pick up real income where like a spending buying power, like really how a person lives may not be so tied directly only to how much they currently make.
All right, Larry, in your last 30 seconds, do you want to give us a summary of you want to say a few words in your last 30 seconds?
Thank you. No, I really, really appreciate the opportunity to present this information, and look forward to, if anybody thinks of a question, we'd be thrilled to have an opportunity to respond, and really excited to see this move ahead and work with Joe and the rest of you on creating a common database for California and a tool to evaluate health impacts of the decisions that you all choose to evaluate and make.
Thank you very much, Dr. Frank. Fantastic. Now, in our last few minutes, we have a special guest, Dr. Baca, she's a senior health advisor to the Governor's Office of Planning and Research, and Dr. Baca came down actually to the Inland Empire and I think in other places here to talk about the active transportation grants that we're all working on nonstop till next week, and I really appreciate her being on the call, and she's going to talk about the Strategic Growth Council and some updates. Dr. Baca.
Hi. Well, thank you for having me. And I have to say it's just even, we've been talking a lot about the bringing together public health and planning. It's where I spend a lot of my time, and I think it's such a great opportunity. Even today, some of the emails that have come through are really exciting about the opportunities that lay ahead of us as a leadership role. As you can tell from listening to Larry, there are a lot of technical details, and I think it's really, it definitely is not an easy task. One of the technical advisory committee members, I love what he said, and I think about it often, and he said something along the lines of, wow, this isn't easy, but it's a start, and it's something we really need to think about for future generations and our children. So on that note, I think, as Larry mentioned, it's really been, even all of the technical details, it's been really nice to have a group come together. So the Strategic Growth Council has facilitated bringing a group together to be able to do a review with a lot of expertise present. The process is being facilitated by the Center for Collaborative Policy, and it's been really fantastic because I think one of the things that we've seen is as we're bringing these fields together, we're looking at things in different ways. Many of the things that Larry mentioned, they're challenging questions, and you have to really think through them and think in a different paradigm and think beyond the tools that we currently have. I think a lot about this when I was going to the Active Living Research conferences a while back, and you've seen the publications grow exponentially around the association between the built environment and health. So Larry actually mentioned a lot of the folks who are participating, and many of you are on the call today. You can feel free to jump in on the process and say what you think. But we have members from Health and Human Services and the California Department of Public Health, Caltrans, local health department representative, SGC, and OPR. The TAC representatives...
We don't know what all that means. We don't know what those words mean.
Oh, OPR is the Office of Planning and Research. So that's the office that I'm part of. And then the Health and Human Service Agency, California Department of Public Health, and a local health department representative. So everyone on the steering committee is really a part of the process, just to be present, to see that the process is being done in a transparent way, to also really provide a link to a lot of the work that's happening on the ground, and how it aligns with state priorities. And then the Technical Advisory Committee is really brings so much expertise in, thank you, you pulled it up on the screen, where we have folks from a lot of different backgrounds who are really thinking about some of these technical issues, as Larry mentioned, the crow, the fly, all of those things are very important and really important to get down into the details. A big part of the process has been really a lot of ongoing bidirectional feedback, so looking at some of the challenges around what data is available, what makes sense for the California context, and potential applications. The other piece I think that's really key is one of the discussions we've had a lot with any tools of this nature is really what the tool, where it can be applied and where it can't be applied, and what some of the strengths are. And so I think too, I don't know if anyone on the phone was familiar with the Fresno example. Did anyone see how data was used for Fresno?
Yes.
Who said the yes?
This is Rye from the Safe House to School National Partnership.
Oh, fantastic. And maybe you could provide a little bit of your thoughts on how data was used for their general plan update.
Well, I think that just being able to tell the story and give decision makers a clear understanding of the benefits of one scenario over the other is really important. And so I think that's what we're hoping is going to come out of this related to active transportation and public health. So.
Yeah, no, you said it perfectly. And so I think that's really how we're seeing it. It's a great opportunity to bring together community, health leaders, and to look at different scenarios, to say this is where we are and these are different options. And I think ultimately it's really about having informed decision making, but it's really a start. And so, the next piece is really very rigorous ongoing monitoring, and a big part of that is going to be doing this in partnership with local departments of health. So that's why it's so important to be having this kind of conversation with everyone on the call today. So thank you for having me.
Thank you, Dr. Baca. What's the time frame, do you think, that, I know it's a hard question, what's the time frame for that work to be done, or it could be available?
So Larry would be able to answer that better, but we're going to be looking, right now it's been more around the methodology and really getting that established, and now it's going to be looking at some of the first data runs. And Larry, I don't know if you have a time estimate on that.
Sure. We're hoping to get the data all in hand over the next, to in a condition we can start to integrate, spatially match together the households from both of those surveys, the health and the travel, with the urban footprint grid surface. I think that'll happen, probably is starting to happen, and will be done maybe by the end of May. And then in June we'll start some of our first, testing the data, cleaning it. So I would think by mid-July we'll have some of our first kind of preliminary analysis, and we'll meet with our advisory group around that time to get feedback. So end of August probably we'll have some results to start to apply. But the tool won't be really finalized and up and running till the early fall.
Right.
Not too far from now.
Yeah, and just so that everyone on the call is aware, so SACOG, which is the Sacramento Council of Governments, is going to be using the tool, hopefully, if timing all works out, to do the first run. So we're hoping to really learn a lot from that process.
I have to leave right now, but I want to thank everybody very much, and hope you all have a wonderful afternoon.
Thank you, Dr. Frank.
Okay.
So, Carla, Tracy, thank you, Dr. Baca. And Carla, Tracy, next steps, I know we're supposed to be meeting and talking about our letter and visiting with our local transportation and planning folks.
So, well, I think we'll probably conclude it here since we're over time, but
Okay.
We will be letting you know about next steps and our topics for some of these upcoming calls. If you have any follow-up questions from this call or would like to discuss any of these issues further, please let us know. But I just want to thank everyone for being on the call. Thank you, Michael, for leading our call. And
Carla, this is Tracy. Just one more thing. If any of the health departments are seeking letters of support for their ATP grant applications, we are writing those on your behalf if you request those from us.
That's right. So just let us know if you want to request one of those.
I want to go as record. We started 3 minutes late and we're ending 1 minute after the time, so we made it in 58 minutes, guys.
Thank you. Good
Thank
leadership.
you.
Thank you, everybody.
Thanks.
All right.
Have a
Bye-bye.
good day.
Bye.